spine surgeons from the Max Smart Hospital. The first one speaker is Professor Bhavuk, who is the Principal Director and Head of the Orthopedics and Spine and Max Smart. He is AIMSonian throughout. He's been in the faculty in AIMS since last 26 years, and he has multiple fellowships in spine deformity correction. And the second speaker with us is Dr. Vishant. He is the senior consultant Max Smart, and he is also from AIMS. And together at Max Smart, they have received the prizes of being among the world's best 16 teams of spine deformity correction. So over to you, Dr. Bhavuk.
Thank you. Thank you, everyone. I'm Professor Bhavuk, and as Dr. Pawan told you that I was Professor of Orthopedics at All India Institute of Medical Sciences, New Delhi, and I spent around 26 years of my life at AIMS. I spent around 26 years of my life at AIMS, and now I left AIMS and I'm Smart again. So I will be showing you something where the neurosurgeons also here too for it. This is something called the Spinal Osteotomies, and this is our team actually, Max Rise, which we are given the name. So we are the pioneers of the robotic spine surgery in India. We started robotic spine surgery in 2019. So basically we have formed this something called Max Robotic and Integrated Spine Institute of Excellence called Max Rise, and this is our team. So we have a dedicated spine team, and we have a dedicated anesthetist. We have a dedicated neurophysiologist who monitors nerves during the surgery, and this is our team. So coming to the spinal osteotomies, they are very challenging surgeries, and we are the pioneers of several techniques which we are given to world, to make these surgeries safer. And these are very powerful tools. We cut the spine into multiple places and then we rejoin the spine. So you can see that these sort of deformities, we correct them on the table itself. And we use various artificial tools that we cut the spine, how we can cut and how it can be made straight. There are several types of osteotomies. I am not going to detail, but there are the grades. It starts from the simple osteotomies and then we go with the combinations. So this is like a simple osteotomy where we just take out a simple piece of bone from the back and then we correct the spine. So this you can see, this is a child with Marfan syndrome, and he was having this sort of back, and this is his x-rays. You can see that there is a severe kyphosis here. So we just cut the spine into multiple places in the back and then we made it straight. And this is the post-op you can see. This is again a case of something called Sherman kyphosis. Again this was bent like this, and we just took out small pieces from the back and then we made it straight. And this is, you can see that, this is a case of, this is how it looks like, that we cut the spine and then we try to move it. You can see that the spine is moving where we have cut the spine. And this is the correction which we can get, like these severe case of scoliosis. You can see that this we almost make them straight. These are some of the cases. This is again more severe variety of cases where we make them almost straight. Changing the life of the patient throughout. And this was again a very severe case where the child was operated somewhere else, and now she is presented to us with the deformity above and deformity below. And this was, the child was shifted towards one side. And when we opened, there was a thick sheet of bone actually in the middle. So we cut the spine into top and bottom, and then we fix the spine like this, and this you can see that the child is almost straight now. And this is the post-operative. Now the child is completely straight, and this is, I think, now 8 years post-follow-up. And somehow, in case of ankylosing spondylitis, we get these sort of the problems. So you can see that the spine is shifted way up, and the C7 is actually way in front of the sacrum. In these cases, we put a cage in front, and then we cantilever the spine into correction, and then we can get this sort of correction. And this you can see that now the person is straight after this surgery. Next, we come to another variety of cases where we take out this sort of wedge from the spine. This becomes more challenging because now we are taking a big triangle of bone from the spine, and then we close the spine. So this is called the pedicle subtraction osteotomy. So this is a case of congenital kyphosis. You can see that the bones are fused here. So we cut the spine here. You can see that I have taken my instruments here and we are taking out a triangle of bone from the spine. And if you see intraoperatively, you can see that I have taken out the triangle from both the sides of the spinal cord. And then we close this procedure. And this is the correction you can see in the post-operative period. This is another case of a post-traumatic one where we have again the child presented with this thumb, and again we cut the spine and made this straight. And this is the post-operative. You can see the child is completely straight. We can also do it at the upper thoracic spine where the spinal cord is there. It becomes more challenging, but we again now are able to do it and we get full correction here. And this is the child in the post-operative period. Now we also do these sort of osteotomies in congenital scoliosis. You can see that this was a very severe curve. And we did the same osteotomy here, and we made this girl straight. And this girl is, I think, now 7 years post-op. This is again a very severe variety of scoliosis, and we can get this sort of correction. And you can see that how the child is straight after the. In India, actually, these childs they present very late to us because most of the time they don't think that there is a problem, and when the child goes to the marriageable age, then they come to us for the marriage. Now we come to the next severe variety that. In the initial cases, we just took out this wedge, but now what if we take out this much wedge? So this is something which we started at Cmes, and this is now we can get around 60 to 70 degrees of correction here. So this was a child with PB kyphosis, post-tubercular kyphosis, and you can see that there is a 76 degrees of kyphosis here. So we again do several maneuvers during the intraoperative techniques, and we break the table. And then during the correction, we made the table straight when we taken out the. So this is how we cut the bone here. This you can see that I am putting my osteotomes and I am taking out the wedge, big wedge. And then we correct it. So this is the correction from 76 to we could get a 50 degrees of correction. And this is the child. You can see that she has got around 50 degrees of correction with these osteotomies. And this was the most severe case which I did from this osteotomy. There was 115 degrees of kyphosis. And this girl was 22 years female and she came to us with balloon chest because for the last 15 years she was like this. And if you look at this is quite rigid kyphosis. And if you see MRI, D7 to L2, the whole spine was fused with single mass. So when I was doing the osteotomy at D7, I was getting the signals in the L2 nerve roots. So this was the severity of this case. And then we cut the spine like this, from this thing. And then we closed this gap to get the kyphosis correction. And from 115 degree, we could brought her to 54 degrees. And you can see the correction, after the surgery. And this was quite satisfying correction for the child, as well as her breathing has improved, her appetite has improved and everything. Now this was a 3-year-old child who presented to us with this kyphosis here. Now the problem is that as there is no growth in the front, the spine keeps on growing posteriorly and then spine dislocates. So this was earlier important case. The problem is that if we operate in a very young child, the average blood loss is around 2 liters. Now operating in a 3-year-old child with 2 liter blood loss was a challenging issue. And then we adopted several techniques. We were very fast. We could finish this case in 1.5 hours. And we cut the spine like this. And then we use burrs. And this you can see all the nerve roots we have to identify and carefully separate it. And then we could close the gap. And this was the correction. You can see that the child is completely straight. This was another severe case where the child was not only bent in the side plane, but she was also having a coronal deformity. That means the spine was shifted to the other side also. And then again, we use this technique. And something we started in India is called the 3D printing jigs. So I was given the award by the government of India in 2013 for developing this technique in India. That we make these 3D models and then we use these 3D models onto the patient, and we put the screws through these screws. And this is the correction. Now this is the most severe variety. It's called the vertebral column resection. That means we take out the whole of the vertebra around the cord, and there is nothing in between. So only spinal cord is there. And then we correct the deformity. So this was a 18-year-old male who came to us with this deformity. This was a case of neurofibromatosis, and you could see that the whole vertebra is shifted to the other side. You see in the CT scan, the whole vertebra is extruded from the other side. So we had to go from, this was the child from the back, and this is his mother, who was also neurofibromatosis. And this child was having a very severe deformity. And there was a dural ectasia also. That means that there was no pedicles. So because everything was, dura was going inside the pedicles also. So we made the patient in the lateral position. We went from the front, and then this is the IVC and the aorta. We tied the vessels, and then we took out the L4 vertebra from the front, from the abdomen. And then we went from the back, and then we took out the rest of the vertebra from the back, and then we corrected the position. And this you can see that this much correction we could get for this child. And this is the child after say 3 weeks. Now we can also do these sort of cases in the cervical spine. In cervical spine, the problem is that the vertebral artery is there. So now getting correction and taking out the bone from the cervical spine becomes more challenging because the vertebral artery is there. And this child was like this for last 12 years. And there was a big sinus here also from the heat tuberculosis. So this child was not able to see in the front, and this was from the back. So again, there was no literature on this technique. So we devised a surgical technique. We went from the front, we burned everything, and we just left the bone around the vertebral artery in the front. And then we put a small cage there to stabilize it. Then we flipped the patient back. Then we went from the back. We burned everything from the back. Again, we just left a small bone around the vertebral artery. And then we just corrected it. We broke those bone, whatever was left in the vertebral artery. And this you can see that we could get the correction. And then we again went back from the front. And we put a bigger cage on the plate, and this you can see that this sort of correction which we could get. And this is the child after the surgery, and this is the child after 6 months of the surgery, and she is doing fine now. I think this is 12 years ago. Another severe case which we did for the same surgery, and this is the beauty if you see here, that this is the space which we get. This hole is the vertebral artery, here is the spinal cord, and we have to put this 3 mm screw through this 3 mm space. And all this was done freehand from the back, and we could get this sort of correction. This we actually published for the 3-year-old boy, again very severe deformity, and we use ultrasonic scalpels to get the correction deformity. And this is the child after the surgery. Again, these sort of cases which we kept on doing, we kept on improving large surgical techniques, and then we started something. These sort of complex, we take out the whole of the bone from the lumbosacral junction also, and we could get these corrections. This is again a very more severe case in the thoracic spine. This is something called Cmes deformity, where there are 2 humps. So there was 2 kyphosis here, and we could get the corrections in this child. Very severe cases which could do. This was a case where there was a severe deformity in the lumbosacral spine, and the sacroiliac joint was dislocated. You can see that the sacroiliac joint was also dislocated. So again, we had to do something very severe, something new, and we took out the whole of the bone from the back. We took out everything from the front also, from the back only, and then we corrected something called 2 screws into the pelvis, and then we could get the correction from this child. You can see that this child is now straight. Now we can get more severe cases. Now this child was having deformity at the cervicothoracic junction. Now it was challenging because arch of aorta and all the severe things are there in the front, and taking out spine from this region was very challenging. And moreover, you can see that the scapula was touching the mandible, and the ribs, they were touching the pelvis. So this was very painful for the child. And then again we had to devise the surgical strategies, and this was the multiply operated by the neurosurgeons for the spinal cord anomalies, and this was the CT scan. And then I did the correction. I took out the bone from the cervical spine, and Hobbs angle actually changed from 87 to 51 degrees. And you can see that this is the correction which I could get. You can see that the scar actually has moved to the other side. Such powerful correction was there that actually the scar moved to the other side. So this child becomes very well. You can see that this hump was also corrected from the back. Now this is something called which we described to the world. We made these surgeries safer, and we could actually cut the whole of the spine from the side of the spine. So you can see here that this spine is intact here, but we have taken out this front of the spine from the back itself, and you can see that the spinal cord is pulsating here. This becomes much safe because the spinal cord is still hanging from the lamina and the spinous process. So this is something which we gave to the world, and after this we could correct these sort of severe deformities. These sort of anaconda spine we call them. And we could correct them, and this is the correction which we could get. And this child also got married, and he sent this picture to me from Nepal. And this is again very severe deformity. Nobody could touch him in the world, but this is the hump, and this again we use the same tactics, and we corrected this child with this surgery. And this is you can see from pre-op to post-op. And this was again more severe case. So this child was having this spine. So the whole of the spine was actually lying as a horizontal support in between the two spines. So there was a jet spine. And again we corrected this with this technique. So you can see that this is the correction. 6 months after the surgery, she is doing perfectly fine. Now this was a child of around 3.5 years and he presented us with neurofibromatosis with very severe deformity at the upper thoracic spine. And if you see his AP view, you can actually see the canal through it. So the whole of the canal you were able to see on the AP film. And again we had to use these special strategies to correct the spine. And the problem was small screws we had to put, and then we had to combine a lot of instruments in this thing. Once we were, able to do all these cases, then we moved to more severe cases, and then we joined these cases. These sort of osteotomies, we were able to combine them. And we also gave these techniques. So this was a very severe case, like this patient was restricted towards one side, and the spine was like this. So we joined multiple small osteotomies, and this we could get the correction. This was another severe case. Again, there are methods of calculations we do. A lot of mathematical calculation is there and how much correction we have to achieve. And then we use multiple osteotomies of different types. And then we do these corrections. And so this child is now straight after this thing. You can see the post-op correction. This is another more severe variety. Again, we have to use the 3D models to understand that how much correction will give us the actual, the correction in the spine. And we also put this on the table because placing them on the OT table for anesthesia also becomes a challenge for these patients. And we also use cement augmented screws with them. And then we have to do the correction, multiple osteotomies and the correction with cement augmented screws. This was more severe variety. Again, I had to cut the spine totally at 2 places. And this was this thing, and we get the full correction here. And this is the patient in the post-operative period. This patient has not seen his abdomen for the last 15 years. And he was bent like ankylosing spondylitis like this. And this was his spine. You can see it's like a cow spine. And then again, we cut it into multiple places. A combination of BCR, ESO and SPOs. And we could get this much of correction. And this is the patient after the surgery. This is the most severe case which I have done till now. So I had 2 vertebral column dissections, 70 degrees of correction at 2 places in the same setting. And this was the child's, this was the patient's, the movement. This was how she was walking for the last 22 years, I think. She was 47-year-old, and this was her X-rays. And then we did the correction, so you can see that from this to this she has moved on the table itself. And this is the correction, multiple rods, multiple osteotomies we have done. And this is the patient after the surgery on the 3rd post-op day. So these are very complex procedures. We do it under neuromonitoring, and there is high potential neurological deficit. Our techniques have made them quite safer now. And blood loss is a problem, so we use multiple modalities like ultrasonic scalpel, hemostatic agents, tranexamic acid. We have to maintain the blood pressure all the time, more than 90 mm mean blood pressure, so that the perfusion to the cord is maintained there. And there is a dedicated team actually required to do all these procedures. Thank you.
Excellent presentation, sir. We'll have the question and answer after both the presentations. So please, sir. So I invite the next speaker, Dr. Nishan. He will be speaking on the awake spine surgeries.
Thank you, Dr. Pawan. So now we will move from the Dhurandhar type of spine surgery that Dr. Bhavuk showed to a more simple, soft rom-com kind of spine surgery. So surgery for low back pain or sciatic or degenerative spine disorders is not uncommon, and it is basically the bread and butter surgery for most spine surgeons. And I'm sure everybody here would have heard of someone or seen someone in the family who has undergone a lumbar spine surgery, that is surgery in the lower back, at some point in their life. So what I'm going to share here is our experience with the same spine surgery that most people do, but in a new andaz. So this is actually, we call it as the awake spine surgery. And this is a USP of our team. This is something that we can offer to our patients which most surgical teams in India cannot. So this is a new way to look at the same spine surgery that has been going on since years. And this is thanks to evolved techniques. And here the patient stays awake. So most of the times spine surgery you must have heard is done under general anesthesia, where the patient is anesthetized and not conscious. In awake spine surgery, the same surgery is done, but the patient is awake, and basically this avoids general anesthesia related complications. So what all can we do as a part of awake spine surgery? These are in fact the most common surgeries that people beyond a certain age undergo. So we can do multi-level discectomies, even endoscopic discectomy. We can do lumbar laminectomies, so decompression surgeries of the lumbar spine. We can do lumbar fusions up to 2 or 3 levels, generally recommended up to 2 levels. And we can do short to intermediate constructs up to the D12 level. So these are the surgeries which we can do keeping the patient awake. What we cannot do is surgeries which require intra-op nerve monitoring. So it is the kind of surgeries which Dr. Bhavuk showed. And surgeries where there is obviously a contraindication to regional anesthesia or spinal anesthesia. So the man you see next to Dr. Bhavuk is Dr. Alok Sharan from New York, and together these two are the pioneers of awake spine surgery in the world. Their textbook on awake spine surgery is considered to be the authoritative text on this topic, which most readers who want to practice the spine surgery refer to. And we have also published literature in some of the most reputed journals in the world, both on awake spine fusion and on regional anesthesia in spine surgery. Now, why awake spine surgery should be preferred over giving complete general anesthesia to the patient? The first and foremost reason is that it makes the surgery safe. Now, we know that spine surgery is feared. Beyond a certain age, most people fear undergoing spine surgery purely for the reason that it is considered to be a very morbid surgery and to avoid long hours of general anesthesia in prone position. So, to avoid the morbidity, most people accept a life of pain and disability, much like what our traditional thinking or mythological texts show. But things have changed since then, and people well into their 80s want to remain active, want a life free of pain and disability, and which is why spine surgeries are being offered to people well into their 80s and even 90s. The second advantage is that it leads to faster recovery. So there is a lot of literature that spine surgery done under regional anesthesia as compared to general anesthesia reduces the length of hospital stay. It leads to fewer complications, so it basically avoids all the GA related complications, which are the reasons why most people have to stay in the hospital for 4 or 5 days. It avoids issues related to airway management. It leads to avoidance of post-operative nausea and vomiting and drowsiness that comes with the use of GA drugs. Because the patient is awake, it leads to a complete avoidance of prone position related nerve injuries, because the patient can directly give feedback if that is happening. Avoidance of GA drugs also leads to better management of post-operative pain, and we have seen that in real life when we have operated these patients using awake spine surgery. And it also leads to a reduced operative blood loss. Like I said, avoidance of GA drugs gives us a more free hand in post-operative period, because we have avoided all the GA drugs altogether. So the patient's body, when we get him in the post-operative period, the patient's body is practically free of all medications, and we have much more options to exercise with, especially opioids, in managing the post-operative pain. So these patients do much better in the post-operative period compared to patients undergoing this surgery in GA. And especially in elderly patients, post-operative pain issues are the primary reason why they develop delirium. These patients often have to go to ICU after spine surgery, and delirium is not uncommon in these patients. So this is also avoided. Another advantage is the patient experience. So we have had patients who listen to music of their choice. Generally, you must have seen this happening in cataract surgery. When my father underwent cataract surgery, he could listen to the prayers of his choice. We had a similar patient operated last week who chose to listen to Gurbani, and we played that, and the experience for the patient changed altogether. The patient can also talk to the surgical team. So this basically allays his anxiety levels and keeps him stress-free. Because GA is avoided, the patient can start fluids and semi-solid diet almost immediately. So psychologically, this is a huge advantage. Now, what is needed to make awake spine surgery work? So first is the surgical techniques. So minimally invasive surgical techniques, which we have mastered. Modification and anesthetic techniques, which I will come to, but which heavily rely on spinal anesthesia using a select formulation of drugs and on locally administered blocks. It also involves very careful case selection and preoperative preparation in terms of priming the patient for what is to come. And it needs a well-coordinated surgical team. But most importantly, what is needed is experience with the technique, which we have developed over years. So like I said, case selection, preoperative patient counseling is very important. The patient has to be primed. The patient should know what to expect, because the patient will be lying prone, hearing to all sorts of instruments of spine surgery while the surgery is going on. So the patient should know what to expect, and this basically needs very good communication between the surgical team and the patient in the preoperative period itself. Preemptive analgesia is also something which we have been using. So patients are given IV paracetamol and pregabalin in the preoperative period, night before the surgery itself. So this helps us reduce the intraoperative analgesic requirement. The anesthesia technique is basically based on spinal anesthesia, in which most lower limb surgeries are done. Here, bupivacaine is used as the primary agent with clonidine as an adjuvant. Of course, we have other options as adjuvants also. So this is basically the anesthetist preference. And based on patient requirements, other drugs can also be used. So erector spinal blocks are another thing which can be used. And so these are administered under the expert hands of our anesthesiologist under ultrasound guidance. So this is again, this leads to very good post-operative pain relief for almost the next 24 hours. The patient is pain-free. So, and anyway within 24 to 48 hours, the surgical site pain comes down drastically. So it is always the first 24 to 48 hours which are the most stormy. And this period is covered by these ultrasound guided blocks. So this is how it is administered. This is an erector spinal block in the muscle. Post-operatively, we try to reduce the use of opioids by giving multimodal pain relief. So we use a combination of NSAIDs, PCA pump with fentanyl, IV PCM and tramadol. So we try to use a mix of drugs, and basically the use of opioids is kept to a minimum because that is associated with the side effects like nausea, vomiting and constipation. So these are just the pictures of our minimally invasive surgical technique with which we do lumbar fusion. So after intraoperative marking, we give percutaneous incisions like this. The screws are inserted using very small pinhole stab incisions. And as you can see, special tubular retractors are available. So with a 2 to 3 centimeter incision, we can perform the entire fusion procedure. Even multi-level fixation can be done using minimally invasive surgery. So this is fixation across 5 or 6 segments. And this can be done with small stab incisions only. And we also have navigation in our OT. And very soon we will be having a robotic arm. So these are aids to a more precise and accurate and safe spine surgery. Time is of essence, especially in awake spine surgery. So spinal anesthesia basically can only be given safely for up to 4 hours. And to have a margin of safety, you need to finish your surgical procedure in less than 2 hours, which is not possible for most surgical teams. So a shorter duration leads to lower dose of anesthetics, fewer complications, which leads to faster recovery and shorter.
Both of our speakers, and now I would like to ask a few questions, one or two questions, just for Sir Bhavuk. Sir, you showed us multiple cases of deformity corrections, including the extensive, which are usually among the highest level of spine surgeries that are being performed. So, as you all know that these are extensive surgeries, involve a lot of blood loss. So, what are the complications usually involved? What are the levels of morbidity faced by the patient in the post-operative period?
So usually, I always tell my residents that the time is blood in spine surgery. So you have to be very fast. So most of the complex surgery which you saw, I'm sure as a spine surgeon you'll be knowing that most people take around 13 to 14 hours to perform these complex surgeries. But believe me, I have done these surgeries live also. We finish all of these surgeries within 4 to 5 hours. So this requires very careful, very meticulous, the experience, and the surgery is very fast. The faster you do, the faster the recovery. So this is something which we have developed our surgical techniques that we are very fast at doing this. A simple TLIF surgery where the average surgical time is 3 to 4 hours for average spine surgeons, we are able to finish in 17 minutes. So this is my surgical time. My fastest TLIF, the one which I showed in a neurosurgical conference, it was 30 minutes live. So which usually people take 4 hours. So again, this timing and making your surgery fast, safer is very important. And the basic precautions like use of the multimodal anesthesia, use of the anesthetic techniques, making your mean blood pressure higher always during the critical periods is again of paramount importance. So if you do this, the complication rate in our series, which I am doing for last so many years now, is less than 1%. And this data we always present. Every year we have to present to our society, Scoliosis Society, and it has been consistently less than 1%.
It's commendable, sir. Such level of extensive surgeries with less than 1% comes definitely with a lot of expertise over the years that you have developed. One more question, sir. This level of spine surgeries require extensive preoperative planning and multi-level fixation also. So what is the role of neuro navigation in these?
So yes, they are very important. For me, I am much comfortable with freehand, but I have everything in my theatre, the navigation, the robotics and everything. So I have this kind of, so there are two kinds of robots right now. The one is which is fixed to the patient. So if you are using that navigation or robot, it has to be fixed to the patient. But which we use, we have floor mounted robot and everything. So whenever I need, it can come in. So most of the cases we just use them for confirmation. We just don't use it for this thing, for the experience. But yes, if there's a very complex cases like neurofibrosis and this thing, then navigation plays a huge role.
Okay, sir. One question for Dr. Nishan. You showed us an excellent presentation on the awake spine surgeries. There are very rare centers which are performing these kind of awake spine surgeries. But one question to you that when these nowadays that spine is having a minimally invasive, multiple techniques of minimally invasive spine surgeries have come, and usually the operative time is also less, like 1 to 1.5 hours or so. So, with how many patients do you think would choose these kind of surgeries in which the patient is very prone and maybe there are chances of airway compromise during the surgery? So, patient selection becomes an important task.
Yeah, so initially awake spine surgery was developed with the aim of being able to offer surgery to patients who are too sick to get general anesthesia. So generally, people with cardiac problems, people who have had strokes, everybody wants to avoid general anesthesia. So initially it was developed as a tool to offer to patients who are too sick. But gradually things got on and became so popular that now we even offer it routinely to our patients because we are able to execute most of our surgeries in less than the critical time period of 2 hours during which spinal anesthesia is going to work for sure. So then it does not become an issue. Room positioning and spinal anesthesia rarely becomes an issue for us.
Now also, would you prefer a patient with multiple comorbidities to go for this surgery?
For multiple comorbidities, this is definitely preferred. General anesthesia, avoidance of general anesthesia is a huge advantage in these patients.
So, it becomes a difficult task for the anesthetists to manage a patient such thing like multiple comorbidity, having a preoperative respiratory compromise, or maybe a heart condition is made prone and maybe obese. So it's a difficult task.
Actually, we are not using the traditional OP tables. So we are using this special kind of OP tables where there is nothing in it. So actually, a plumber is actually hanging simply using Jackson kind of tables. So if there is no pressure on the chest or so actually these patients will be more comfortable because they are awake. They can adjust their breathing and everything. So it is similar to
Okay, thank you. Now the house is open for discussion.
So I think we can stop discussion here and you can ask your questions. अपने सवाल ना इधर से पूछो, उधर मत करो, ठीक है? मैं आपसे I just wanted to ask you, Bhavuk, how should we decide whether we should send our spine cases to an orthopedic surgeon or to a spine surgeon, or to a neurosurgeon? Because that we don't know. Everyone, it's like I remember after I did my MD medicine, I was very fond of writing MD medicine, consultant cardiologist. Then I discovered no, cardiology there is no fun, right? Then I discovered that diabetes is the thing to go. Now I write myself as consultant physician and diabetologist. So then I saw some of my friends writing consultant physician and neurologist. So I saw one of my friends writing consultant physician and clinical cardiologist because he didn't want to get into an issue with the DMC. So how should we decide? Is there any way of knowing who will be a good bet, whether an orthopedic surgeon who says that he specializes in spine surgery, or somebody who says no, he's a neurosurgeon, so he is the best bet for spine?
Sir, normally when the spine surgery started, actually it was distributed with neurosurgeon and orthopedic surgeon. So the neurosurgeon, they used to do the intradural. That means if there is a tumor inside the spinal cord and there was no body work in it. So the body work, there the screws, rods, fixation, everything used to be done by the orthopedic surgeons. Deformity is something which we in India right now. No neurosurgeons do the spinal deformity. Regarding the usual this thing, now they are being done by both of them. But I prefer that if I have to send somebody to my person any intradural work, if any C1, C2 work, I will send it to a neurosurgeon. But rest of the thing I will send to some orthopedic surgeon.
So you don't do craniovertebral anomalies?
So craniovertebral anomalies we don't.
You don't?
We don't.
Right. Dr. Sajid.
So excellent presentation. We were overawed by what you are doing. Since I'm a general physician, common question coming to mind is how does the spine and your spinal cord behave when over the years it has become a C and now you straighten it out? How the extra part you manage to put inside the spine must be a problem. I mean, the length is definitely more than what you reduce it to. You cannot change the length of the spinal cord. One thing. Another thing, what happens to other organs, like the lung has, has found a new space now, and the heart, the position is changed. That is a common question coming to my mind, maybe a very general question, but what happens to the other organs rather than on the spine?
Actually, we try to make the spine the normal, which was abnormal previously. So actually the lungs and the heart, they were actually fitted in a very tight space, which was not normal for them. And actually these patients, they have poor appetite because their stomach is very much crumpled inside this thing. Their stomach is not able to expand. Their lungs, they are not able to expand. Their heart is not able to beat to its fullest extent because something is stopping them in this thing. We just make that normal. Regarding the spinal cord finishes at L1. Then there are the nerve roots. So we have to be very careful when we are doing. We don't stretch the spinal cord, never. Stretching is the worst thing for the spinal cord. We try to shorten the spinal cord because spinal cord can tolerate shortening but cannot tolerate lengthening. Even lengthening by 5 mm or 6 mm is very bad for the spinal cord. So again, this is something where our skills come, that we try to, play a sort of game intraoperatively, try to manipulate it into such a position that we are not overstretching it, but we are kind of shortening the spine. And that's, we keep on monitoring through the spinal cord monitoring. And again, to the world, we have given several new techniques for something called dynamic spinal cord mapping. Again, this is something which our team has given to the world, where we can actually tell when we are doing the correction at so many levels, at what level exactly is the problem. Thank you, sir.
Dr. Bhavuk, what happens to the nerves? See, if you remove the whole spine from what happens to the neural foramina? The nerves come together. Compression nahi hota.
That's what I'm saying, sir. Again, we are very careful that the nerves, they not get injured. So we keep the nerves intact while we take out everything in between them. And then we correct the deformity.
But they don't get compressed.
No, they don't get compressed. That's why I said. So again, when we take out the bones, so there are 3 nerves actually in one neural foramina. But there is a big neural foramina.
Okay. And any experience with conditions like ankylosing spondylitis?
So all those cases which I showed you in the end, they were all ankylosing spondylitis.
All ankylosing. You operate them?
Yes. Even we cut the spine also for cervical spine also for the ankylosing spondylitis. It is bent like this. So we correct this from the back.
वो कहाँ गया शेखर कहाँ गया
So let me commence by saying Dr. Bhavuk, very complex cases that you showed with remarkable results. So pretty amazing. So talk us, a recent article was published in Orthopedics and Traumatology just recently, about 2 months back, and they talked about modern techniques like the hinge preservation technique. So you using that?
Which techniques are hinge preservation?
Hinge preservation technique.
I think you are talking about cervical myelopathy.
No. We are talking about osteotomies in grade 4 to 6.
Yes, so again, this is the hinge preservation. So I was talking about that we preserve the posterior structure. So we preserve the posterior structure and then we do the osteotomies. So this reduces the chances of neurological complications.
Absolutely. So chances of neurological complications is markedly reduced here. And this is really pretty amazing. So to our friend, Dr. Mehta, you talked about awake spinal injuries. Would you know which was the first awake surgery done in the history of awake surgery? Anybody of us would know? Dr. LMP would know surely?
One was sleeping and one was
Okay, let me say it was in 1886.
We were not born. Certainly I was not born.
Open radiotomies were done. And from that, they took this and the spinal surgeons started doing this, awake spinal surgeries. So as you correctly said, a lot of advantages of doing awake spinal surgeries. And the indications would be, as you said, spinal fusions. Don't do more than 2.
We have done up to level 3, sir. 3 levels.
Till level 3?
We have done up to 3 levels.
Great. And laminectomies, disectomies, etc.
Fusion.
We talk about that. Okay, and now, why would you like to do spinal surgery or a brain surgery in patients who are, who have the lesions are very near to the speech area, the vision area? area or the movement area. So this primarily seems to be the basic fundamental of doing a awake surgery. I think that's about. Thank you.
I'm Dr. Kalra. Regarding awake surgery, Dr. Tulsi has said about 1886. So I saw a sculpture in Slarjan Museum in Hyderabad. So a person is being operated. Actually at that time there was no anesthesia. And people are holding, there are muscular people keeping him not moving. And then the expression shown on everyone, the surgeon, the person, and the holding people was really amazing. So anyway, sir, my question has been asked twice. First by Dr. Siddiqui and again by Dr. Sadeva. What happens to, as you have shown in one of your slides, that there was no vertebra around, only spinal cord. Is there a scope of artificial vertebra?
Yes, sir. So there are scopes of artificial vertebra also, but it's a metal again. We by 3D printing, if for some tumors we are taking our vertebra, then we can form these special vertebrae with metals, and then we can replace them.
As you said that we can't elongate our spinal cord, we can't even compress it. It has to be kept.
Spinal cord shortening is tolerated to some extent.
Compression of cord itself is again pressure on it.
No, not pressure, sir, shortening.
Yeah,
I'm saying shortening, not compression, shortening.
So my last question about erector spinae block. So erector spinae is muscle. So muscle block versus nerve block. But which one is better?
Sir, actually the erector spinae block is by blocking the nerves which supply the erector spine. Because when we are doing the surgery, we are dissecting the erector spine. So basically we are denervating the erector spine. It's a nerve block.
It's a nerve block.
No.
Sir, there are some instances we see videos that people are being hypnotized and we are doing surgeries on them. My question is, why we are not using this technique in India, and how they are able to hypnotize the person and doing surgeries?
Sir, so you must be knowing about ketamine. Ketamine is something called dissociative anesthesia. It dissociates you from the surroundings. There is something called digital sedation, which we are actually working upon with IIT Kharagpur. We are doing this, this study. So basically, we are using these VR sets, the virtual reality sets. For children, we are trying this study that we make them wearing this VR set. So we dissociate them from the surroundings by using VR set. And then we are able to do small procedures on them, like IV needle, IV cannula, and all those things. So that sort of thing is being done in the world right now. This is called digital sedation. But how it will evolve into the future, this is something we have to look at.
But sir, hypnotism really works?
Dissociative anesthesia works. I'm not sure about hypnotism. I've never tried it. But dissociating one person from anesthesia, from surroundings, which is similar to hypnotism.
Thank you.
I just wanted to ask you regarding the cost of showed some wonderful cases. So, what would be the approximate cost?
So depending upon the levels of fusions required, the surgery cost varies at max, varies from 5 lakhs to 12 to 14 lakhs.
They are covered under CGHS?
They are covered under CGHS.
All insurance panels?
All insurance panels, unless they are congenital. When it is something from the birth, then they are usually not covered. And otherwise, most of the cases they are covered.
Most of these conditions are usually congenital.
No, it is not, sir. Like ankylosing spondylitis is not congenital. Adolescent idiopathic scoliosis, which is the most common thing, it is not congenital. Post-tubercular kyphosis, post-traumatic kyphosis, again they are not congenital.
The congenital ones are not.
Unless their parents are insured for their birth.
That's very
So they sometimes
So I would now give it to Dr. Pawan to summarize this. Vipul, you have a question? Please, I'll come to you.
Thank you for the wonderful presentation. I just had one tiny question. So a lot of these spinal deformity kids, they come to me for pre-op echo and everything. Now, although majority have no concomitant congenital heart disease, but let's say there are cases which do have congenital heart disease, as one would expect. Now, if there is stable congenital heart disease, what is your priority? Getting that repaired or getting the spine repaired?
Usually, if there is something which can make the patient surgery safer, I mean these surgeries are stressful conditions, so and they can wait. Deformities can wait for a year or so. This is not a problem. So we always prefer to get all the corrections and optimization which can be done. So all the heart problems, all the neural axis anomalies, if they are not being able to done simultaneously, we prefer to do it before.
These things, they fare well after corrective surgeries?
Yes.
So how long would you actually wait?
So 3 months we usually give time before the cardiac correction procedures and the surgery. And we are doing it for so long. And we have operated patients with pacemakers, with all sort of shunts and all those things. But again, we need an anesthetist, which is something, someone who is fairly well versed with the management of these disorders.
Thank you so much.
Dr. R.K. Sinha. Very simple and practical question. Once it comes to our patient, we can refer freely for spinal surgery. But once it comes for our relatives or near and dear ones, everyone fears spinal surgery. So how you allay this fear, that is also very important in counseling.
We can always make them speak to our previous patients who are happy. So that is the biggest motive. So when we were doing these deformity cases and AIDS, so we were having a scoliosis clinic actually. So patients, they usually sit outside, all pre-operative, post-operative, and then they usually talk to each other. And then most of the patients, till the point they come to us, they were already well versed that this is going to be this thing. And now we have enough videos, our patients and this thing, who can always vouch. So our scoliosis patient is doing dance on 7th day after a surgery. So that is again a big videos and everything which are available. So I think that is enough to allay your anxiety.
Any question? Any question? I would request Dr. Pawan Chaudhary to please summarize this wonderful CAT for us and what is the carry-home message for all of us.
Excellent presentation today by both of our speakers. So as we approach the end of this enlightening session, I would like to congratulate both of our speakers, Professor Bhavuk and Dr. Nishan, for such a beautiful presentation on such type of gigantic, I would like to say, surgeries which are almost among the most difficult performed surgeries in the spine field. So showing such results of less than 1% complication rate, as you told. So it completely allays the fear. So that such cases of scoliosis and complex deformity can be easily and very well handled by such experienced team. So thank you so much for
I request both my speakers and my moderator to please come here.